The investing layer of deep cervical fascia splits into two layers to enclose the sternocleidomastoid, splits into two layers to enclose the trapezius. So splits and encloses two muscles. It splits into two layers and encloses the submandibular gland, splits into two layers to enclose the parotid gland. So splits and encloses two glands. It splits into two layers in the midline of the neck and both layers are attached to sternum. So if there is an infection between these two layers, it can seep down up to the jugular notch, that is the upper part of manubrium sternum. It will not go beyond. However, if the infection occurs between the investing layer of deep cervical fascia and pretracheal fascia. Pretracheal fascia is the fascia covering the thyroid gland. So if the infection is between investing layer of deep cervical fascia and pretracheal fascia, it will slip down into the thorax, into anterior mediastinum, the mediastinum in front of the heart. The mediastinum in front of the heart is called anterior mediastinum. Behind the heart is called posterior mediastinum. Above the heart is called superior mediastinum. The mediastinum is a space lying between the two lungs. And between the two lungs lies the heart. Front of heart anterior, behind the heart posterior, above the heart superior. So this investing can go to the in front of pretracheal. It is through this layer space that thymus gland, which develops in the neck, goes to the anterior mediastinum. That is normal, but infection can follow the same path and go into the anterior mediastinum. If the infections within the pretracheal layer, that means including the thyroid gland and an infection within that, the pretracheal layer goes to the superior mediastinum and it merges with the tunica adventitia of the arch of aorta. The pretracheal fascia, which encloses the thyroid gland, and any infection between the two layers of pretracheal fascia, including thyroid gland, can go only up to the superior mediastinum, because the pretracheal fascia has two layers, fuses with the tunica adventitia of the arch of aorta. So after that it can go any further. Now, forget about mediastinum itself. Mediastinum comes from the Sanskrit word Madhyasthanam. What lies in the middle? Middle of what? Middle of the thorax. Behind the thyroid gland is the trachea. Behind the trachea is the esophagus. If the infection is behind the pretracheal fascia, that will track along with trachea and esophagus. And along with esophagus, it will go to the posterior mediastinum behind the heart. So you must understand where is the infection and how far can it spread. So between pretracheal and prevertebral layer are those layers of muscles which surround the longest pori, scalenus anterior and erectospinal. This is called as, the space is called as retropharyngeal space, which communicates with the posterior mediastinum behind the heart. One must understand that retropharyngeal space has got lymph nodes which are called as retropharyngeal lymphadenitis. There is a septum from the prevertebral layer to the prevertebral layer to the pharynx, which divides the retropharyngeal space into left and right spaces. From the prevertebral layer, there is a septum to the pharynx, which separates the retropharyngeal space into left and right, which do not communicate with each other. So if there is an enlarged lymph node in the retropharyngeal space, retropharyngeal lymphadenitis, it can be either to the left or to the right of the midline, not both sides. So when the person opens his mouth, you can see the swelling on the posterior pharyngeal wall, which will be to one side of the midline. Then you know that this is an infection somewhere in the pharyngeal region, which has spread to one of the two groups of lymph nodes, either left side or right side of the midline. So when you see a swelling on one side of the midline, on the back of the throat, when you open the mouth, it means it's a retropharyngeal space infection. In contrast, if the space is behind the prevertebral layer, the septum was in front of prevertebral layer of fascia. If the septum is behind the prevertebral layer of fascia, which includes the vertebral column infection, it will be a midline swelling. Because there is no septum separating one side or the other. When you open the mouth, and you see a midline swelling, you know it's the vertebral column infection. If it's a pyramidal swelling, you know it's a retropharyngeal space swelling. And as you said, the retropharyngeal space will slip with the pharynx, esophagus, and go to the posterior mediastinum behind the heart. In contrast, the prevertebral fascia stops at T4 vertebrae. Prevertebral fascia of the neck stops downwards at T4 vertebrae above the heart. Heart lies opposite vertebral level T5, T6, T7, T8. And this fascia fuses the vertebrae at T4. So infection behind the prevertebral fascia will stop at superior mediastinum. Remember we said space above the heart is superior mediastinum, in front of the heart is anterior mediastinum, behind the heart is posterior mediastinum. So this infection cannot go beyond the superior mediastinum. So this fascia earlier were an exercise in futility because neither X-rays nor CT scan can show fascia. All this could show only bones. But nowadays with the advent of MRI sees the fascia quite clearly. You can actually see the disposition of different fascia in the living person. And then you can predict when you want to remove the pus, how far deep it has gone. So where did you take an incision? How will you remove the pus from the body? Remember, pus anywhere in the body has to be surgically removed because even if you treat with antibiotics, the pus will become sterile, the bacteria will die, but the pus will still be in the body. It has to have a way out. That is only through surgery. So when you take an incision, where will you drain out the pus, which is the lowest level the pus can go, All these things are important because gravity will also pursue go as far low down as possible. Prevertebral fascia lies in front of subclavian artery but behind the subclavian vein. Prevertebral fascia in the neck lies in front of subclavian artery but behind the subclavian vein. Subclavian artery goes into the axilla to the cervicoaxillary canal. Subclavian vein also goes into the axilla. Or you can say the other way around. Subclavian vein has come from the axilla. Because blood is flowing from axilla to subclavian vein. And artery, subclavian artery to axilla. As axillary artery. When subclavian artery goes into the axilla, it carries a sleeve of the prevertebral fascia into the axilla with a new name, axillary sheath. Subclavian vein, artery, because it was lying behind the prevertebral fascia. When it goes into the cervicoaxillary canal, it carries a sleeve of fascia. In this sleeve also lies the brachial plexus, because brachial plexus also lies in the plane of subclavian artery. So the nerves and the artery lie within the sheath, axillary sheath. The vein is outside the axillary sheath, because vein was lying in front of prevertebral fascia. So that is the question which is often asked, that why is the subclavian vein outside the axillary sheath? It wants to remain outside the sheath because it wants to expand during increased venous return. If it was locked in the sheath, it couldn't expand. So it is lying outside the sheath. Actually it is lying outside the sheath because in the neck itself it was outside the sheath. It continues the axilla, the tracing to the axilla, it will still remain outside the sheath. Then the question asked is, okay, fine, if that is meant for expansion of the vein, why in the thigh femoral artery and vein within the sheath and nerve is outside the sheath? Femoral nerve in the abdomen was lying behind the fascia. So it has slipped into the thigh outside the sheath. Whereas the external iliac artery and vein were within the abdomen, within the fascia. When it comes into the thigh, it carries the sheath with it, femoral sheath. Then the question asked is, how will the femoral vein then expand during increase in the system if it is within the sheath? But remember, medial to the femoral sheath, there is a femoral canal, which is an empty space. It is filled with some lymph node, but that lymph node is just the size of a pinhead. So on. So femoral vein can adequately expand on the medial side because there is femoral canal. Then the third question asks is, carotid sheath. Carotid sheath contains within it lower part of the neck, common carotid, internal jugular vein and vagus nerve. And as you go to the base of the skull, the carotid sheath contains within it internal carotid artery, the one which is going to the brain, internal jugular vein, the same vein which was lying in the lower part as well, and vagus nerve. That means all throughout the sheath, the internal jugular vein is inside the sheath. And the artery is accompanying it and the nerve is accompanying it. So, how will the internal jugular vein expand when there is increase in the return? The answer here is, the carotid sheath is not uniformly thick. The carotid sheath is thin around the vein. So it can easily expand, allow the vein to expand in the neck itself. So basically, these three structures, internal jugular vein in carotid sheath, axillary artery outside the axillary sheath and femoral vein within the femoral sheath. All have different ways to allow expansion during increased venous return. Increased venous return occurs during deep inspiration. When there is negative intrathoracic pressure, it will suck the blood from the neck, the upper limb and lower limb. Children, cardiovascular physiology, not fully complete. You are not done. Teachers have taught you. Let me ask you a simple question. During deep inspiration, there is negative intrathoracic pressure. That everybody can understand because you want the air to enter. But during the negative intrathoracic pressure, the heart also gets benefit. So it allows the venous blood to re-enter the heart. Now when the heart contracts, more blood can flow out of the heart, increase cardiac output. Increased cardiac output should raise the blood pressure because after all, blood pressure is a product of cardiac output and heart rate. More cardiac output, higher would be the blood pressure. That is what we expect. But what physiologists have taught us is that during inspiration, the blood pressure falls by 2 to 3 millimeters of mercury. It appears logically absurd that why should the blood pressure fall? They also say further that there is something called a sinus arrhythmia. Sinus arrhythmia means the heart rate differs in different phases of respiration. So, arrhythmia, not in perfect rhythm. And then they say, during inspiration, deep inspiration, the heart rate rises. This is even more absurd. Heart rate rises, greater cardiac output, stroke volume is higher, and rate is higher, and the blood pressure is a product of heart rate and output. Rate is higher, output is higher, yet the pressure is lower. So this is something which you will find out. Why does the heart rate fall despite being a rise in why does the blood pressure falls despite being a rise in heart rate as a sinus arrhythmia and increased venous return also during inspiration. All during inspiration. A reverse will occur in expiration, but we will not focus on that, we will focus on only inspiration. Why, despite increased venous return and increased heart rate, the blood pressure actually falls? Okay, I'll give you 3 months time to get to this answer. You can search wherever you want, internet or whatever, but you have to give me a logical explanation. Don't come out with things like Bainbridge reflex and all those things. Just go by pure logic and should be able to answer. So you have to read between the lines of physiology books to find out why this happens. And the infection occurs behind the pneumotomy division, it can spread to the superior canal or the axilla. Those are the two spaces. And we know that that is because the prevertebral fascia is attached to T4 vertebral level. So it can't go below T4 vertebral level. And we have discussed this also, how to differentiate a cold abscess of cervical tuberculosis with a hot abscess of retropharyngeal lymphadenitis. Retropharyngeal lymphadenitis will be one side of the midline because the septum will divide the retropharyngeal space into left and right arms. Whereas the cold abscess of cervical vertebra behind the pneumatic fascia will be a midline swelling. Why do you call it as cold? Tuberculosis is a very mild infection. That is surprising. Tuberculosis is a mild infection. So the signs of infection is like warmth and redness, etc. will not be there. That's why it's called as cold abscess. Whereas lymphadenitis due to bacterial infection, other bacterial infection of the throat and neck and of those regions is hot, which will have calor, rubor, etc. all those things. So why is tuberculosis such a mild bacteria? Why does it cause such devastating effect and even death of the person? It's not the tuberculosis kills. It's our own immunity that kills. Our immunity acts against the tuberculosis with such vigor, it's like trying to kill a rat with a cannon. If you try to use a cannon to kill a rat, you will damage your own property. The rat may or may not die. Something similar happens with tubercle bacteria. It lies inside the cells. So all immune system which are surrounding the cell can do nothing about it. The only way to control is kill the cell. And likewise many cells get killed. So our immune system is destroyed those infected cells, and that is what produces the devastating effects of tubercle bacteria. Otherwise, if it lies comfortably in our body, then it shouldn't cause much of a problem. So our immune system can't let it lie there. Torticollis or wry neck. Birth injuries, cerebrovascular tumor. Wherever cerebromastoid has got injured, injury will cause hematoma to form. Hematoma will get converted to fibrosis, and fibrosis has a usual habit. Fibrosis has a usual habit of shortening. So one cerebromastoid is shorter than the other cerebromastoid. Automatically, that cerebromastoid will cause the neck to tilt towards that side and face to turn to the other side. That's congenital torticollis. Acquired torticollis can be disease of cervical vertebrae, lymphadenitis, tonsillitis, rheumatism, enlarged cervical gland, retropharyngeal abscess, cerebellar tumors, irritating the spinal axillary nerve. So this is acquired torticollis where spinal accessory nerve is injured. Not injured, it is irritated. When spinal accessory is irritated, it causes contraction of that sided cerebromastoid. Face will turn, head will turn towards that side, face will turn to the opposite side. If the pressure of the axillary nerve continues for a longer time, that axillary nerve is injured. In which case, the other axillary spinal accessory nerve is injured. In which case, the other accessory nerve will overact, causing the head to tilt towards that side and face the opposite side. So, acquired torticollis in the initial stage, when there is irritation of spinal accessory, will cause the head tilt towards the affected side, face turning to the opposite side. And after injury, head will turn to the normal side and face turn into the paralyzed side. So, congenital torticollis is a damage directly to the muscle. Acquired torticollis is irritation of the nerve. Some of these drugs, antipsychotics, neuroleptics, drugs regenerating the basal nuclei, can produce cervical dystonia and spasmodic tachycardia. This is also due to muscle spasm, can be caused by drugs. And the basal nuclei, degenerating basal nuclei, is usually occurring in jaundice of the premature child. In a premature child, the blood-brain barrier is not very good. So what happens is, increased bilirubin level in the blood will pass through blood-brain barrier and causes yellowish discoloration of the lentiform nucleus. Lentiform nucleus, the Greek word for nucleus is kern, K-E-R-N. The Greek word for jaundice, yellowish discoloration is icterus. So you get a condition called as kern icterus, which is basically translated into English is yellowish discoloration of the lentiform nucleus. And that is because of bilirubin in a premature child with blood-brain barrier, weakened blood-brain barrier. That's why you must have seen that such premature children are kept in some orange colored light. The orange colored light is not sunlight. It's a specific wavelength of light which converts the bilirubin into water-soluble compound by photooxidation, and this water-soluble compound will dissolve in blood and will be passed out through urine. Urine will become extra colored, but that doesn't matter. You are removing the bilirubin without when the bilirubin is water-soluble, it need not and does not cross the blood-brain barrier and easily eliminated from the urine. So that particular light is a frequency of light at which photooxidation takes place of the bilirubin, making it water soluble. Here you are seeing two children with turning the face towards one side and neck tilted to the other side. That's called in English as a wry neck, in Latin torticollis. Torsion of the collar. Collar means neck. Spasmodic, that's due to irritation of the neck. Six nerves meet in the lower part of the neck. That's called as Erb's point. C5, C6 root, upper trunk, two branches of the upper trunk and two divisions of upper trunk. So two roots, two divisions and two branches. That's the Erb's point. In the middle of the neck, behind the sternocleidomastoid, there are six nerves. That is called as the nerve point of the neck. Technically, even the Erb's point is the nerve point of the neck. So, to differentiate that was anyway called as Erb's point. You can very well call it as upper trunk of brachial plexus. This point is also called as great auricular point. Great auricular point. So, six cutaneous nerves emerge from the midline of the posterior border of sternocleidomastoid. All are cutaneous nerves, so they are going to pierce the deep fascia there and come to the skin. And the six nerves are at even numbers of the clock. 12 o'clock, 2 o'clock, 4 o'clock, 6 o'clock, 8 o'clock and 10 o'clock. Six nerves. The 12 o'clock nerve is a nerve which runs vertically upwards, supplies the lower part of the ear lobule and the skin over the angle of the jaw. Trigeminal mandibular has missed supplying the angle of the jaw. That portion, the skin over parotid, is supplied by great auricular nerve. Great auricular nerve is therefore an important nerve. It is important from surgeries of parotid also. In surgeries of parotid, do you take a vertical incision or transverse incision? Initially vertical, so that is parallel to great auricular nerve. Retract the skin, take a transverse incision on parotid gland, because immediately in the depth is a facial nerve which is running transverse. Incisions, according to Hilton's law, is to be made parallel to important neurovascular bodies. You say, but the retromandibular vein and external carotid artery are vertical, but they are deeper to facial nerve. If you have gone so deep that you have cut the vein of the carotid artery, that is a bad surgery. The nerve is dividing the gland into a superficial and deep lobe. Vein also. So when you have to remove the parotid, you have to remove it layer by layer. First the superficial layer, then you push aside the vein and the nerve. Then you piecemeal remove the deep part, sparing the external carotid artery which lies within it. And because of the important nerve starting from the nerve point of the neck, the great auricular nerve, this point is also called the great auricular. The other nerve at 2 o'clock, it looks 3 o'clock in this diagram, is the one which is crossing and coming to the anterior triangle. It's called as transverse nerve of neck. Transverse nerve of neck supplies the skin of the anterior triangle. Then 4 o'clock, 6 o'clock, 8 o'clock are three nerves which go towards the clavicle. Medial, intermediate, lateral, supraclavicular nerves. They are lying supraclavicular, but they also supply intraclavicular region up to the sternal angle, second cervical, second rib. So it supplies the region above the clavicle as well as below the clavicle up to second rib. Why? Because C5 to T1 are pulled into the upper limb. So C4 and T2 are in direct connection with each other because C5 to T1 are pulled. So above the second rib, supraclavicular nerve. Below the second rib, second intercostal nerve. Are you getting the point? C5 to T1 are skin which are pulled into the upper limb. That was 4, 6, 8. 10 o'clock is a lesser occipital nerve. 10 o'clock is a lesser occipital nerve which supplies the skin behind the ear. There is no greater occipital nerve. Greater occipital nerve is the dorsal ramus of C2 which supplies the back of the head. Dorsal rami do not form plexus. Only ventral rami form plexus, and that also C1 to C4 ventral rami form cervical plexus, of which these 6 branches are there. Then C5 to T1 brachial plexus, T12 to L4 lumbar plexus, L4 to S4 sacral plexus, S4 to coccygeal plexus. Only T2 to T11 ventral rami do not form plexus. They supply segmentally each intercostal space from second to 11. We said 2 o'clock is transverse cervical nerve and 10 o'clock is lesser occipital. This is if you are seeing the right side of the person from lateral aspect. If you see the left side of the person, then 10 o'clock will be the transverse cervical and 2 o'clock will be the lesser occipital. So we are assuming You are looking at the right arm side of the left leg. Posterior triangle. The only true content of the posterior triangle is the spinal axis. All other contents, subclavian artery, the brachial plexus, they are all lying deeper to the prevertebral fascia, which is the floor of the posterior triangle. So if you consider the fascia as the floor, the brachial plexus and the subclavian artery are not contents. If you are considering muscle as the floor, then these two are contents. So if you are asked to write a full question on posterior triangle, you can't say a full question on the boundaries and contents of posterior triangle. You can't just land up with writing only spinal axis because that's the only true content. All other than beneath the floor, so they are not content. As I said, number of pages into number of diagrams divided by size of handwriting. We've already seen what happens in injury to spinal axis nerve when we discussed torticollis. Compression of subclavian artery. This is important. There is something called Adson's test, ADSON. Subclavian artery lies between scalus anterior and scalus medius. Remember I told you earlier also, I'll repeat again, there are four nerves, four muscles in the neck, head neck, whose relations you should be very clear. Scalus anterior is one of them. Hyoglossus is another one. Medial pterygoid is the third one. And sternocleidomastoid is the fourth. Sternocleidomastoid, scalus anterior, hyoglossus and medial pterygoid. Study the relations on both aspects of each muscle. Scalus anterior, behind that lies subclavian artery, and behind that is scalus medius. So, scalus medius is attached to second rib, scalus anterior is attached to first rib. No, medius is also attached to first rib. But there is a gap allowing subclavian artery to pass through. When these both muscles go into simultaneous contraction, scalus anterior and medius, there are chances the artery which lies in between will get compressed. Usually it does not get compressed. Compression occurs when there is extra rib, cervical rib. T1 is associated with the rib, normal first rib. C7, vertebrae, is normally not associated with the rib. Neck does not have ribs. But by mistake, in the flow, the thoracic vertebrae showed the rib, cervical vertebrae, last cervical vertebrae, C7, may also show a rib, in which case that's called cervical rib. Now the question is, subclavian artery comes from thorax. It wants to go to the axilla. Normally it passes over the first rib and goes to the axilla very smoothly. Now if there is a cervical rib, the question is, will it squeeze itself between the cervical rib and the first rib and then go to the axilla, or will it loop around the cervical rib and go above the cervical rib and goes to the axilla? There are two options possible. It has to reach the axilla, either passing above the first rib, below the cervical rib, or passing above the cervical rib. Remember, cervical rib is a congenital phenomenon. It's not that cervical rib suddenly develops and then obviously the artery was already over the first rib. So this is there since beginning. The artery has to find its way. Artery will always pass above the cervical rib if present. Above all the ribs if present. So that means this subclavian artery has to take a longer course and a sharper turn. It is going upwards, then it has to go downwards in the axilla, sharper turn. That is not a problem. The artery can smoothly pass sharper. The problem is now the space between subclavian, scalene anterior and medius is even lesser. In the first rib, there was a space for the subclavian artery to pass through. But now with the cervical rib, remember, both scalene anterior and medius arise from the anterior tubercles of cervical rib. As it goes down, it spaces out, and at first rib, enough space is there. At cervical rib, it's like a fork. The space is reduced. The artery can get compressed easily. When the artery gets compressed and you are feeling the radial pulse, suddenly the radial pulse will disappear. This was described by a scientist called Addison, and it's called as Addison's test. The question is, how do you cause compression of the artery? By asking the scalene anterior and medius to go into contraction. Now, scalene anterior and medius does not know how to go into contraction. You have to think of some movement by which the muscles will go into contraction. Since these are arising from cervical vertebrae and goes to the rib, considering the rib to be fixed end, it will cause the head to tilt towards that side. When you tilt the head towards the right side, assuming that it is the action of the scalene anterior and medius of the right side, actually it is not. This is the action can be done by right sternocleidomastoid. It's a much bigger, bulkier muscle. And after initial tilting, the rest of the tilting is assisted by gravity. In fact, when you tilt the head to the right side, the scalene anterior and medius are most relaxed. Because sternocleidomastoid was deep action, gravity was continuing the action. The muscle did not contract at all. So what you have to do, you try to turn your face to the right. When you turn your face horizontally to the right, the action of sternocleidomastoid was to look up and turn to the right. Tilt on the left, turn on the right. This is the action of left sternocleidomastoid, turn to the right. If you do not want that unwanted action of sternocleidomastoid of tilting of the head, you have to look horizontally to the right. This unwanted left tilting will be prevented by synergistic action of right scalenes. Are you getting the point? Action of left sternocleidomastoid is to tilt the head to the left, turn the face to the right. If you want horizontally turn it to the right scalenes must act to cancel the unwanted effect of tilting of the head, which is caused by sternocleidomastoid. So where there is a cervical rib, you turn towards that side. When you turn horizontally towards that side, left sternocleidomastoid is acting, and right scalenes are acting, which will compress the subclavian and radial pulse will disappear. So you are feeling the pulse, and turn the face to the right horizontally, pulse disappears. That means the artery is getting compressed. Is this point clear? So that is Addison's test. Without the good knowledge of anatomy, there are some textbooks which have said Addison's test, tilt the head to the right, wrong. Turn the face to the opposite side, wrong. The correct answer is turn the face to the same side, which will cause the synergistic action. And they also said something. Turn the face to the right side, then tilt your head this way, that way, all those things. Nothing of these sorts will cause scaly to contract. Brachial plexus nerve block can be done either supraclavicularly or infraclavicularly. In the supraclavicular nerve block, you do it in the posterior triangle. Subclavian vein catheterization can also be done above the clavicle or below the clavicle. It is easier to do it below the clavicle. So we will not discuss subclavian vein catheterization here. So that intraclavicular approach of subclavian vein catheterization is you pierce the below the clavicle, pierce the skin superficial fascia pectoralis major muscle, the clavicular head, clavipectoral fascia, subclavius muscle, wall of subclavian vein, and into. Remember, subclavian vein is not the content of posterior triangle simply because it is lying deeper to clavicle. And upper border of clavicle is the boundary of posterior triangle. So it is easier to catheterize the subclavian vein by piercing the skin below the clavicle, but there is a method above the clavicle also where you will pierce the skin, superficial fascia and platysma, invasive layer of the sublateral fascia and the wall of the subclavian. See the person on that side, you can see that the right shoulder has drooped down. Right shoulder has drooped down, which means right trapezius is paralyzed. Injury to spinal accessory nerve in the posterior triangle does not affect sternocleidomastoid because it already supplied the sternocleidomastoid. Any nerve which pierces the muscle supplies the muscle before it pierces it. Sternocleidomastoid is an abbreviated name of a muscle which starts from sternum clavicle and inserts on mastoid process and occipital bone, superior nuchal line. So the correct name should have been sternocleido-occipitomastoid. Sternocleido-occipitomastoid has 4 sets of muscles. Most superficial is sterno-occipitalis, which rotates the head. Deepest is cleidomastoid, which sees the head. So most superficial is sterno-occipitalis, deepest is cleidomastoid, in between lies sternomastoid and cleido-occipitalis. I have told you the first and the fourth. The second and third, your logic will tell you which is it, so that it minimizes crisscrossing of minds. Anyway, spinal accessory has come into the posterior triangle immediately superficial to the deepest cleidomastoid. So by the time it was already supplied, so it will only cause paralysis of trapezius. Two needles which are seen above the clavicle, one needle is seen below the clavicle. This is called brachial plexus block. You can do any one of the ways. If you block the nerve here, wherever, either supraclavicular or infraclavicular, the entire upper limb will be anesthetized. And then you can quickly operate on the upper limb anywhere, arm, forearm, hand, without any pain. Okay? Such a type of anesthesia is called as field block. Field block. Another example of field block is put the anesthetic agent in the web space surrounding one finger. Let's say you want to operate on the middle finger. You inject the web space between index and middle and inject the web space between middle and ring. We know there are two nerves to supply one digit onto the lateral side of the middle. You have blocked it in the web space itself, the middle finger will be anesthetized. You are operating on the pulp of the middle finger, that will also be anesthetized. So, field block. When the nerve is blocked away from the site of operation. In contrast, there are other types of anesthesia. One is general anesthesia, where the person is unconscious. The other is spinal anesthesia, where you are injecting into the lumbar subarachnoid space. Then there is epidural anesthesia, which is in the sacral hiatus outside the dura mater, blocking the nerve when they come out of the dura mater. There are field anesthesia, which is less described. There are local anesthesia, that means we anesthetize the local area only. And these are the different types. General, spinal, epidural, field, local. Field anesthesia requires you to have a proper knowledge of anatomy. Simply in catheterization from below the clavicle, the needle is pointing towards the opposite tip of shoulder. If you slightly tilted upwards, that needle along with the catheter will go in the direction of subclavian. So you can come conveniently and easily pass in the subclavian. You can put a catheter here and have what is called a central venous line. When you inject a hypotonic solution into the blood, RBCs will swell and burst, not burn. When you inject a hypertonic solution in the blood, RBCs will shrink and get damaged. So normally you give an isotonic solution. But suppose you want to feed the patient parenterally, and not through oral pathway, but through blood directly. Now, what is required as food for the person is large quantities, and those will be hypertonic. So when you want to give a hypertonic solution, you have to do what is called as a central venous line. The catheter should be inside the SVC. Now even if you give intra-hypertonic solution, the large amount of blood flow which occurs through SVC will wash it out and dilute it. You can't give it in a small way because the vein will collapse. SVC being a large vessel and the flow is rapid there, it rapidly distributes the diameter of the solution throughout the rest of the blood until it diluted. That's called as central venous line. Even when you want to infuse large amount of fluids also, you do a central venous line. Cisternal puncture to be done in a newborn child, because in a newborn child lumbar puncture is not possible. Spinal cord lies at L3. At 7 years of age, it lies at L1. And after that, it lies in the level of L1 throughout his life. But for a newborn child, if you want to collect fluid, you can do by pushing a needle above the atlas vertebrae for cervical vertebrae, below the occipital bone, through the foramen magnum, by pushing the needle 4.5 centimeters in depth. If the needle goes 5.5 centimeters, you have punctured the middle of the abdomen. You don't want to do that. Exactly 4.5 centimeters. Keep a needle guard. Pulse of the carotid versus compression of carotids. Pulsation of the carotid is felt at the upper border of thyroid cartilage. That's where it's easily felt. The resistance on which it can be felt in either thyroid cartilage itself or C4 vertebrae. So feeling the pulse against the C4 vertebrae. That's where you feel the pulsation of the carotid. This is also the site where carotid artery bifurcates. But here, the artery cannot be compressed. If at all, you will compress only one of the two arteries. Slightly lower down, in front of the anterior border of cerebromastoid, you can feel the Chesagnax tubercle. Chesagnax tubercle is the name given to the anterior tubercle of C6. If you press upon the anterior tubercle of C6 on both sides, that will compress the common carotid artery and the person will become unconscious. So in the pre-anesthetic times, when there was no known anesthesia before operating, they used to press upon both the carotids on both sides, person will not feel unconscious, then you release, let the blood flow to the brain. But he is unconscious, it will take some time to wake up. So quickly operate. Wherever he is unconscious. Suppose he wakes up during surgery, press the carotids again and release it. Pressing the carotid for some time, the person goes into coma for some time. Then comes back, but you don't keep it pressed. If you keep it pressed, brain will suffer from anoxia and there will be permanent irreversible brain damage. You just have to press it enough that he falls unconscious and then release it. So the brain is not damaged. And posterior triangle was divided into two sub-triangles by inferior value of wire into an upper occipital triangle and lower subclavian triangle. The lower subclavian triangle, because of the subclavian artery line, the lower subclavian triangle was also called as supraclavicular fossa. More specifically, it was called as a greater supraclavicular fossa. Greater. Between the sternal head and clavicular head of sternocleidomastoid, just above the clavicle, there is a space, which was called as lesser supraclavicular fossa. If you put in a catheter into the lesser supraclavicular fossa, you can reach the internal jugular vein. At that side, the vein is most anterior. Now look at this lesser supraclavicular. Vein is anterior, carotid is posterior. At the base skull, internal jugular vein goes to the jugular foramen. That's why the name of the foramen. And internal carotid goes to the carotid canal. That's why the name of the canal. Because carotid canal lies anterior and jugular foramen lies posterior at base skull. So at skull base, the vein is posterior. At the root of the neck, vein is anterior. So somewhere in the middle, they have crossed. The arteria-centric people say the vein has crossed from lateral to anterior. The vena-centric people say the artery has crossed from posterior to anterior to belong. In reality, the person who is juggling and playing the game is the vagus nerve, where the artery and the vein twist around the axis of vagus. And they change their relation. Anyway, this helps us in reaching the internal jugular vein. If you put in a catheter through internal jugular vein, you can reach the superior vena cava, you can reach the right atrium. From right atrium, you have got two options. Either go to right ventricle and then from there into the pulmonary trunk, pulmonary arteries, or through SVC opening you enter the right atrium. Through IVC opening you can go against the direction of blood. Catheter what? Blood will flow around it. So you can go to IVC and any of the tributaries of IVC, which includes hepatic vein, renal vein, and whatever. This is also part of central venous line because you are reaching the superior vena cava. Heads of cerebrovascular, in between the two, interjugular superior vein, joined to form brachiocephalic vein, which of the two sides joined to form superior vein. With that, we come to thyroid nerve system. We stop here, continue thyroid gland and further part. In our next class, we shall have a longer duration. This will be the last class which I will be taking. After that, you will all go down. Because university exam will be in this one. Stop here.